As promised yesterday, Toshi Funasako from Homolka Hospital will have a review of live cases from yesterday, just to give you an update, because we finished earlier than the case. Toshi, please.
Okay, thank you, Professor. And first of all, on behalf of Professor Newell and Professor Reddy and from Homolka EP team, thank you so much for watching and joining us for the live case yesterday and the day before. Today, I'd like to summarize one of the cases from yesterday, which was done by Farpal. So the case was under general anesthesia. The patient was 66 years old with paroxysmal AFib. And here we have voltage map before and after PBI with Farpal system. So on the left, you can see the healthy tissue in the left atrium. And on the right side, this is after PBI with the Farpal. We did basket shape and flower shape for each vein, and we isolated TD, all TDs. And even the posterior wall was connected like roof line. It's probably connected. The result was quite nice. And during the live case, the issue was that 80, which was seen since the beginning of the procedure, even before the PB isolation. And the cycling was 300 milliseconds. And look at the CS potential. The sequence was from proximal to distal, but the cycling was a little bit changing even during the mapping. So here's the activation map acquired by the PAD system and with the Pentray. We mapped both sides of the left atrium and right atrium. And the AT looks like the focal pattern coming from septum right over here. And first of all, we tried some applications with purpose with flower holes on the septum from left atrium, but didn't work, and we couldn't stop the AT. So when then we decided to go right atrium, and we mapped whole right atrium, and this is the best entry in the right atrium. We're going to show you the voltage map of the right atrium. The interesting thing is the patient had an idiopathic right atrium, huge scar region all around here, on the lateral, on the up here. And here's the activation map, but the signal was so small, it's really hard to see the signal. And we tried some applications here with RF ablation, but it didn't work. And finally, we decided to use pulse width ablation around this area. Actually, the best instrument was acquired here, around here. It didn't work, but obviously the best instrument was not on the septum, but a little bit laterally. And this is a pulse width ablation we tried the last application. We did 5 pulses, and 80 terminated with a long sinus pulse, and he restored sinus rhythm after that. But soon after the termination, the sinus was a little bit unstable with a small pulse like this. So this is the final fluoroscopy with the pulsation. You can see the capture of the phrenic nerve, but the phrenic was not damaged. The phrenic was totally intact after the procedure. Unfortunately, we couldn't transmit the really end of the procedure, but Professor Newell showed the last part of the live session. I'm going to show you the last live session. So 45 minutes after we finished the live transmission, we finally terminated the AT, and the patient recovered totally stable sinus after that. And today, the patient discharged without any complication, and she's sinus right now. So this is how we finished the case yesterday. So that's all from me. Thank you so much.
Okay, thank you, Toshi, for this update. It was quite complex case, I would say, but I was really surprised how big lesions were done in left atrium with this tool. You know, from starting from basically normal voltage, then having the whole area with very, very low voltage.
Yes, those are good points. I'd like to add one information from the patient. The patient was 66 years old, but he was professional athlete. And since he was teenager, he was extremely trained for running. And he was really quite famous runner in Czechoslovakia era. So maybe that's the reason why he had such a large failure in the right atrium, so due to the overpreload from right atrium, that cause of the atrial tachycardia we get.
Okay, so it looks like too much sports does not mean always good. Huh?
That's actually an interesting case.
Okay, thank you very much indeed. And we will move now to our lab. We have 2 cases for you today. And I don't know which one we will start, but with Dan.
Odpovídej. Tak já zůstanu tady.
Už tam jsem? Asi jo. Dobře, takže já můžu nějak natočíte, nebo kam se mám stoupnout? Jsem úplně mimo obraz, jako. Já se musím vyjímat.
Dane, už tě dobře slyšíme.
Dane, už tě slyšíme, jo, tak...
Okay, hello.
If you can speak in English, please. And yeah,
all right.
Let's start the session of life cases with a case of cardioneuroablation. Dan Wichterle.
Hello. My task is to present the case of anatomically-guided cardioneuroablation for recurrent reflex syncope. And I have short presentation of patient. Please, next slide. It is male, young, with no comorbidities. And he suffered from recurrent syncope since 2018. It was infrequent at the beginning and more frequent in the last year. It was usually while sitting with short prodromes suggesting vasovagal etiology, but without clear trigger. EKG was normal, echo normal, Holter non-remarkable findings except of trend to or tendency to sinus bradycardia and prominent respiratory sinus arrhythmia. Neurological examination was normal, including EEG. And reveal was implanted in other hospital in October 2020. He had a recent episode of syncope on March the 27th. And the next slide shows what was found in reveal memory. There was sinus arrest of duration, let's say, minimum 9 seconds, but if we don't consider the 2 escape beats, the pause was 14 seconds, and it was associated obviously with loss of consciousness. Please, next slide. It is his normal 12-lead EKG. There are no abnormalities. And we obviously performed a tropin test, not just before the procedure because it would destroy all the vagal reflexes, but yesterday. And after administration of 2 milligrams of atropine IV, sinus rate of 59 accelerated to 92. So this is pretty good response. And it indicates that the cardioneuroablation should be optimum treatment for this young boy. Next slide. And I would like to conclude what is scheduled just now. It is a radiofrequency catheter ablation procedure in general anesthesia. It is 3D navigated with Carto 3 system and facilitated by intracardiac ultrasound. We will show how it can be guided by extracardiac vagal nerve stimulation, and not only right vagal stimulation, but bilateral vagal stimulation. And that's why, because our procedural endpoint is complete denervation of sinus node and AV node. Learning objectives are how to perform the procedure anatomically, how to find the most efficacious ablation sites, so-called sweet spots, how to minimize the lesion set, and of course, how to utilize extracardiac vagal nerve stimulation. Next slide. And these persons are with me on board. Predrag helped me in mapping and introducing the catheters. Now he is helping in the other EP room. Helena Jansova is EP technician sitting at Carto lab, at Carto and Cardio lab, and we obviously have anesthesiologist team because we need not only general anesthesia but also myorelaxation because of this vagal stimulation, because during vagal stimulation there is inevitable capture of motoric axons. So without myorelaxation, there is very unpleasant cramps in upper part of thorax and the neck. So myorelaxation is needed, and we have our EP nurses. And I think that's all. We may continue with case itself. We already prepared. I don't know what you see just now. Probably Carto should be on the main screen, and probably signals. I'm adjusting eyes just now. All right. So can you see Carto just now? Not yet. Please, Carto. Yeah, really? Because I can't see. Yeah. All right. I see just now. So what you have seen on there are three structures mapped anatomically: right atrium, left atrium, and coronary sinus. Please rotate, and I will explain the details. There is also right atrial appendage mapped by FAM mapping. There is activation sequence in sinus rhythm in right atrium. If we look at it in PA or right lateral view. So this is the activation map of right atrium to exactly know where the sinus node is, just to be on safe side when ablating in proximity. And there is also curves of phrenic nerve. These light green points indicate phrenic nerve capture, and this was identified prior to myorelaxation, because after myorelaxation, which continued during the procedure, we obviously can't test the proximity of phrenic nerve. So it is mapped just in advance. And our strategy usually starts in ablation in right atrium. But before we do the first ablation attempt to denervate sinus node, I will show how we do baseline extracardiac vagal nerve stimulation. So please now switch to fluoroscopy, because and you see already, this is RAO view, and there are two catheters introduced via jugular veins, internal jugular veins, right and left, and they are close to the base of the scalp. And now I will start manipulating with that decapolar catheter, which is located in the right jugular vein, and I will find the optimum position. This is usually at the level of upper molars, because it is a clear landmark, and there is also mastoidous processus visible. So I think this is the optimal level to do the first right vagal nerve stimulation. We slow down the sweep speed on Cardiolab just to see the inducible sinus pause after we start. We may even slower, just to, I don't know, maybe slower is better to see the long, how the pause is long. All right, so the position is all right on the fluoroscopy, and we may start the pacing. The output is pretty high. It should be up to 70 volts, according to, of course, body weight. And frequency is 50 hertz, and pulse duration is very short, only 50 microseconds, not milliseconds, microseconds. All right, so this is technical parameters, and please just start now. So we do pacing in sinus first. Prosím, zrelaxujte ho víc. Jo. Tohle je nedostatečný, jo? All right. So we have seen pretty long pause. Of course, and sinus haven't restarted after, I think the first is junctional, maybe the second is junctional as well. And what we always measure is the interval between the last and first atrial beat. This is ventricle probably, because this is junctional without atrium. I don't know. I can't see from this. All right, but it is more than 10 seconds. Now we should wait a couple of, at least 1-2 minutes, because there was not enough, patient was not enough relaxated. So there was some not significant movement, but we should wait, and then we will do the same maneuver with during atrial pacing. And we may start pacing just now, pace 100 from coronary sinus. And we simply assess whether the same response is there on the level of AV node. So now we are pacing, and there should be complete AV blockade. All right, I think, yeah. You see, we just started. It can be recognized by artifacts on surface EKG. And there is again, we may measure from the last QRS to the first QRS, and there is this short, yeah. So again, maybe 7 seconds, 8 seconds, yeah. It's long pause again. And the same can be just now. It is not pathologic response. It is response of normal. This is not like test for if it is correct diagnosis of cardioneuroablation syncope. Of course not. This is physiological response. But our goal is to eliminate this response by ablating in correct sites around in areas of ganglionic plexi. And the same response, and I will not show just now, can be achieved by pacing from right vagus. Sometimes, if the response is weak, or we may try to show. I just reconnect the catheter, reconnect the output of this high frequency stimulator to left vagus. I will adjust the position of decapolar catheter in left jugular vein. And we may at least try to pace in sinus rhythm just to show that the response is in this patient rather symmetrical. Go. Sometimes the pacing of left vagus may be useful for assessment of especially AV nodal denervation, because when after some ablation at lower ganglia, you may see that after high frequency stimulation of right vagus there is already no response, but when you switch for pacing of left vagus, you may have nice response again. So it indicates that the full denervation was not achieved. All right, so we tested everything. There is nice response for both vagal nerves. I will go back to right vagal. and just to be prepared for testing during the procedure. And now please remove the left atrium, and I need to have PA projection to right atrium. Maybe it is also included in my lecture, which will be broadcasted after this live session. So maybe there is no need to comment in details, but this point, this is the right atrium sweet spot, this dark violet point. This is very posterior and along the axis, or long axis of superior vena cava. And it is at the level of the roof of right appendage. Right appendage is here. And usually we don't use this thumb mapping of right appendage, simply use some tags along the roof, and it indicates us the most antral part of SVC right atrium junction. So this is the correct, just not only because of efficacy, but because in terms of safety, it's better not to be too deep inside SVC because of risk of stenosis. So now the position is perfect. I'm do some small adjustment. Prosím, trošku mě to zatočte, ať vidím opravdu, že na tom bodu stojím. Já se tam ještě takhle přijedu. I'm adjusting the position, and we apply 30 watts, 30 seconds to this region. It is safely away from phrenic. Trošičku doleva. Jo, dobrý. All right, so I think we may start burning here, yeah, a blade. Vezmi lepší pozici, stačí mapa. A nebo pusme, jestli tam něco je vidět taky, já nevím. So usually there should be acceleration of sinus. I don't know what was the sinus rate prior to this delivery, but we may check after the end of this ablation. Yeah. So now the sinus is 81. What was the sinus before? Sorry, 50. So there is acceleration by now it goes down, so maybe 75, it's plus 25. But it doesn't tell nothing. It is not this good. Yeah, of course, it is good sign if we observe acceleration here, because it might indicate a good denervation, but it should be tested by extracardiac vagal stimulation. And that's why we may test it just after this single lesion. I will again check the position. Check the position of catheter in right jugular vein. I think it's correct. It's important just to be exactly at the same side, because in some patients it is really dependent on the position. All right, so I'm ready to, yeah. So extracardiac, yeah, right valgus. Yes, no.
Can we see signals?
What you see?
We see cardio.
It's not
okay,
bad.
Perfect.
Because you see, of course, long pause but this is AV block. And there was maybe very small slowing of sinus from 67 maybe to 54. It is probably the longest sinus pause, or not pause, it's interval. But so sinus is almost denervated. There is some residual vagal activity, at least by pacing stimulation of right vagus. But still, of course, because we didn't intervene yet the inferior ganglia, there is still long AV block. Just to make this lesion or make this denervation more durable, I always burn from the other side, from the aspect of left atrium. And please give me a left atrium RAO just to be able to get back to we have a lot of difficulties with transseptal puncture, because there was very unusual morphology of the septum with some double layer. We had to use safe sept, and it was really difficult. But now I was able to get back easily. And look at this yellow point in the anterior vestibule of right superior pulmonary vein. Pulmonary veins are were not mapped because they are irrelevant for cardioneuroablation. So you only see the ostia of right veins and left veins tagged by these white points. And now I am sitting here anterior to the right superior vein. This is exactly the same point, contralateral to this right atrial point. So when we add the right atrium map and adjust the view or use some low transparency feature on Carto, you will see that I'm sitting just contralateral to the first lesion at the posterior aspect of junction of right atrium, superior vena cava. But because of the thickness of myocardium or some other structures here is variable, it is always useful to ablate from both sides, just to make the lesion more permanent. So please remove right atrium. And we will give again 30 watts, 30 seconds here. Yeah, please ablate. A little bit unstable, but I think at the end it's because of respiration. My normal strategy is to give usually two burns from right, 2 burns from left, but if it is enough if it is nicely denervated by 1+1 lesion, it is probably sufficient. All right, so it's done, and we will recheck again, because sometimes may happen that simply this configuration of ablation lesion may also denervate the AV node. This is quite rare, but we have already experienced such a nice effect already by simply ablating these superior ganglia. So I'm adjusting again the catheter in right jugular vein. Its position is now all right, and we will repeat the test. Likely the response will be the same. So no slowing of sinus and huge AV block. Yeah, we started just now. All right, you see quite stable sinus, and please look at it more. Yeah, this is exactly what I predicted. There is significant improvement in AV conduction already after the superior ablation, because you see that the maximum pause, this is probably 2:1, or I don't know, yeah, 2:1. So the maximum pause is not less than 2 seconds. All right, I think it is. Now it is time to switch to the other EP room, because otherwise we may continue after the pause, and we will target the inferior ganglia to show how to finally eliminate the responsiveness of AV node.
Okay, can we move to the other lab? And that should be cryoablation of inpatient with paroxysmal atrial fibrillation. Can you hear us? Okay, you are.
We can't hear you. We can't hear you.
You can start your presentation.
Okay, we can hear you.
And nurses Misha and Alice, and technician Sarah. Sarah waved to us. She's there. Okay, and Drag will introduce the patient, please.
So can we move to the next slide? So we have here a 62 years old patient who was scheduled for catheter ablation due to the symptomatic paroxysmal AFib. Despite the anti-arrhythmic therapy, he has a sleep apnea, and he's quite big with BMI of 35, and he's tall as well. He's on uninterrupted rivaroxaban, and he has a normal ejection fraction with dilated left atrium and no significant valve disease. Next slide, please. So this is ECG. On admission, we see atrial fibrillation. Next slide. But after one hour, spontaneous version occurred. So he's now in sinus rhythm. Next slide. So for the purpose of this workshop, we did for you CT reconstruction of the left atrium, and we see quite normal anatomy of pulmonary veins.
In fact, we are never doing CT anatomy before ablation. We just did after many years, just for the reason of this workshop, to show this anatomy.
Next slide. In order to prevent phrenic nerve palsy during right-sided pulmonary veins ablation, we will monitor right diaphragm excursion by palpation, and in addition, we will continuously monitor motor action potential of the right diaphragm by using additional bipolar lead placed over the right diaphragm. So we will show you what we have so far.
Okay, we have, can we see eyes? Can we see eyes picture, please? Okay, you can see balloon inside or idiostome of the left superior pulmonary vein, and achieve, we can show X-ray now, achieve going into superior branch of this left superior pulmonary vein. Can you show us CT? Can you rotate it, please, a little bit? More to the right. More to the right. To the right, the other side. You can see that it has two branches, one superior and one inferior. The achieve is going mainly to inferior branch, but now we are in the superior one. So we are ready for first inflation of the balloon before first cryo ablation. We can expect that the temperature will be not so high because there is a cooling, there is a short common trunk, and there will be no cooling, warming of the balloon from inferior vein. So we can inflate the balloon, please. Okay. And can we go for eyes to show Doppler recording? You can see there is a curl going from left inferior vein, but not from superior portion of this left superior vein. So there will be warming of the balloon, so from inferior vein, so the temperature we expect will not be very high. So I think we are ready for first ablation. Stop Doppler, please. And can we see not signals, but we don't see too much signal because achieve is quite high because it's not stable there. But can we see temperature of the balloon? As I said, we don't expect it will be too low because of warming of the balloon from inferior vein.
Yeah, we have eyes there. Okay.
The typical application will last 3 minutes. In some cases with lower temperature, we can prolong to 4 minutes. If the temperature is too low, below 50, we will shorten it. But in this case, as I said, it will be, we don't expect it will be too low. So we have almost 40 degrees minus. ACT is 307. So we are giving first dose of heparin before transeptal puncture. In fact, in this case, the transceptor was not so easy because the patient is really big. He has 120 kilos and the septum is quite thick. Okay, we can use signals before in the ostium of the left superior vein. Sarah, show us. Move it to the left. To the left. Now you can see, no, there's an ectopy. More to the left. Okay, there's a signal in the ostium of the left superior vein. So we will check after this ablation. We will give 220 in this case. 220 seconds. So we are now minus 44. And at the end, you will maybe appreciate ice storm going from the vein. After deflation of the balloon, we can see sometimes or very often ice storm. It is a good sign of good occlusion of the vein. We will show then after some recordings from previous cases of these storms. So we are nearly in 200 seconds. Minus 45 degrees. 10 seconds more. We later will prolong time of ablation because the patient's really very big one.
So can we see the eyes? Yeah, we see it there.
It's warming very slow. Now the bubbles are only from the perfused sheets.
Yeah.
It's 1 minute after we stopped freezing, and still balloon is now.
Let's wait.
Let's wait.
Now.
And now you can see it is enormous ice storm going from the left superior vein. It's a good sign that the vein was nicely occluded, and we can expect that it will be isolated also. So we will check now. One ice balloon is going out, but lasso achieve.
We are in the ostium now.
We are at the ostium. Do you see achieve at the ostium?
There was one dissociated potential.
And
this is
it's isolated. These big signals
far
disappeared.
fields, yeah, from the.
They are far field from the appendage. So
Nice.
left superior vein is isolated. So now we'll move to left inferior vein. There are signals in left inferior vein. We are going with achieve. We try to go into inferior vein, inferior branch of this inferior vein. So it's okay, we are there. So we will move balloon a little bit inside. Okay, we can now inflate balloon. Okay. And we try to go by position of hockey stick there, but we also show it is.
Maybe a small leak.
But I think it's
But
quite
it's fine
reasonable.
because we can pull back. Yeah. Nice. nice occlusion now.
Can we go with Doppler there for inferior portion? No,
This is superior, yes.
Flow going for superior vein. It's short common trunk.
And this is a...
There is a small leak on inferior portion.
But it's okay, I believe.
But with pulling down, I think it will
We
be
will
okay.
close it, yes.
We can close it.
Okay, remove that.
Stop, remove the Doppler. And we can start freezing there. The temperature also will be not very low because of warming from superior vein. Yes. Maybe after this ablation. We will do force. We will go for small pull down after this.
There is a question from the audience. How many procedures do you perform yearly with cryo? Could you hear me?
That was a question for us?
Yes, of course.
I can't hear you properly.
How
Can you
many
repeat it?
cryo procedures you perform yearly in our center?
Approximately 100. It's about less than 20% of all AFib ablations.
Okay. And then what is the share between paroxysmal and persistent AF using cryo balloon?
We try to do only paroxysmal AFibs. We don't do ablation for persistent ones because we can't exclude there is some scar in the left atrium. So for persistent AFib, we prefer to ablate with RF.
It has to be also mentioned that we test a lot of new technologies for persistent or for other ablations. So there's some patients are suitable for other trials and technologies, of course.
The temperature is not very low. As I explained to you, there is a warming from the superior vein. But I think occlusion is quite good. We have minus 38 to 39. We'll go to 220.
If I can comment for people who are watching, I think it's a nice example how ice can be used to avoid unnecessary contrast injection, because you can see with Doppler very nicely if there is occlusion or not, and you can see the other vein with flow. So it's very nice tool to check position of the balloon and also if there is occlusion or not.
In fact, we almost never do angiography of the vein. Maybe in some special anatomy twice a year. There was more ice storm, but it was much smaller than in the inferior branch, the superior branch, and we will just check signals there. I expect that there will be still some signals there.
No, dissociated.
It's
Yes,
dissociated.
there is a leak there.
Oh,
No.
This is one.
It's not isolated.
Oh. But it's proximal, is it?
You can see that we are. Can you record it, please, once again? Show us signals before ablation. Yes. You can see that the signal is delayed here,
Yeah,
but
it's
it's not
delayed.
isolated.
Yeah.
We try another position of
Yeah.
the balloon.
I believe it was visible there was
Second
dissociated potential, but then it reconnected after some time.
Yes, maybe it reconnected.
Yeah, one was clearly dissociated. Or maybe it was more distal when we are pulling down the, or out the...
There is a question.
Okay. Yes.
There's a question
Please.
which you already answered, whether we use CT for every case.
No. We did it just for this workshop. We almost never do the CT before.
We used to do 15
Because
years
almost
ago,
every-
maybe, but at that time
Yes,
we
did
learned
it
how
for,
to
for,
understand
we
anatomy.
did it for
And,
registration or something.
Yeah.
Okay, we can inflate balloon, please.
So there's a question: what is the lowest temperature?
Yes.
What is the lowest temperature which you don't want to exceed?
55, minus 55. Okay.
Teďka je to možná lepší takhle napřímo.
Can we see put Doppler there for inferior portion there? Still there is a small leak. Do you see it?
in the middle is an artifact
portion
from
of
the
the
probe, but you see
Yes, but there
lower,
is still some small.
lower
small
portion. On lower portion there is some
Yes,
small leak.
Usually we can. We can close it by small pull down.
Yeah,
It's
they are
bigger now.
the veins are relatively big. I mean, for an average patient,
It
No,
seems
he's a big
to us,
guy.
but in fact we tried to measure it. It was about 21, 22 millimeters.
which is not so small.
Put the Doppler away, please.
Now it's
This looks good.
better maybe.
Yes, it seems according. Okay, can we freeze?
Okay, so once you're freezing, there's another question from the audience.
Yes.
What do you do if you have a left common?
If we have not so big left common, it's okay, because we can freeze separately superior inferior portion of the common trunk. But if it is a very long, a very big one, then there can be some problem. But we can't isolate it left common trunk about once or twice a year, and then the patient is going for next ablation via using RF. So it's a very rare condition. So in this case, we have also very short common trunk. Can you move the CT a little bit to the left? CT to the left, please.
Can we see the CT?
Can we see the
More?
CT, please?
So you can see there is a short common trunk there.
Yeah.
Okay.
Can you rotate a little bit to the right? The CT scan, can you rotate to the right? So we see the anterior portion of the veins. Even more. Yeah, this is actually normal anatomy. And we did, one of my colleagues, Hanka, today, her name is Vinchova, she did a study a couple of years ago with MRIs, and we showed that this is actually in 80% of cases you have at least such a short trunk that you have common part anteriorly between appendage and left veins, and posteriorly there is some bigger vestibule. Only rarely you have
And
a
you can
really...
see that the osteum is not, yes, osteum not so round, it's always some oval. Move it, CT again to right, and you can see this oval orifice in the superior vein.
They are always on left side, they are oval, and on right side they are more rounded. Especially right superior vein
Yes,
is,
that's right.
that was from the study Hanka did. I mean, the most rounded vein is right superior, which is also most funnel-like shape. And that explains why you have a risk of phrenic nerve injury when you ablate a superior vein on right side, because it's a funnel shape. The balloon can go inside and then it can expand the vein and get to closer proximity to the phrenic nerve. So this is all about anatomy.
So we have now much better temperatures than in previous ablation. We have -45. So occlusion, not using this hockey stick from the roof of the left atrium was better. So we have -45 now, so 210.
Well, this is great.
And we expect it to be a big storm here. So we can stop it now, okay? And we will see. And after this, we will show some examples of ice storm that's pre-recorded from previous ablations.
There is a question whether you use sometimes pressure-guided cryoablation, which also reduces the volume of contrast and fluoro. I mean, it's probably measuring pressure inside the vein, but I think if you have Doppler on board, like we see, there is no need for any contrast. There is no need for measurement of pressures.
Yes. And we will wait now.
Can I show the signals now, or maybe the storm first and then the
Yes,
signals?
we must wait a little bit to warm it. Yes,
Now,
you can see
storm.
big
Great.
storm there.
So this is another proof that there was good occlusion if there is such a snowstorm.
Exactly.
Can we see the
And
signals?
we check now signals. We are at this ostium almost. Yeah, we are out now. We are in the superior.
It's far
We are
field.
going inside, and there's
nothing there, yeah.
There's nothing. Perfect.
So it's isolated also this vein. And we will show you now some examples of the storm going from all four veins. Can we see the presentation of this ice? Can you comment it, Predrag?
Can we put it on main screen, please?
Ice storm.
Main screen.
Yeah, we cannot actually because it's not connected.
Well,
to the-
they can put it on main screen. This
Put it on the
picture.
main screen,
Aha,
please.
okay.
Okay.
Yes, now. You can see a balloon in all four pulmonary veins, and you can see ice storm going from all veins. So it's a really good sign of good occlusion of the vein. And in almost all cases with this sign, the vein is then after isolated. And now you can see some piece of ice,
No,
big piece.
Next slide,
Next
please.
slide, please.
This is quite bizarre case with.
Yes. Now you can see the piece of ice, quite big one, going from right superior vein. Do you see it?
Yes, it's
There's
very nice.
Cooling.
Big piece of ice.
It's good. It's ice.
It's actually an ice cap flying away after the
Yes.
deflating of the balloon.
Okay, we can, if you want,
Now we will-
continue with right superior vein. Now we will show pacing from the diaphragm using the CMAP. Can we pace, please?
So we have a catheter introduced into the SVC, and we are pacing.
And you can
Now.
see this CMAP potential. Okay, stop it. And we will go. Will you join us for other veins, or will you go
Yeah,
for a moment?
maybe
to
one
Jan
more
back
and then
again?
we go back to Dan because
Okay.
we have
okay,
about
okay.
half an hour to go for live cases.
Please inflate and deflate.
On ice, you can see right superior pulmonary vein, and this one is right inferior.
So we have signals in the right superior.
This is right inferior, actually.
Right inferior. Okay, we are going
This
to.
is probably superior branch.
We are going to superior.
Whenever you see
This one
pulmonary,
is right superior.
whenever you see pulmonary
You
artery,
can see
it's
we
right
are in the left
superior.
superior vein now. Can we record signals?
There are big signals.
We are going with achieve inside. Then we are going over the wire with balloon, a little bit to the vein. Can you inflate balloon, please? So balloon is outside the vein, you can see. We have slight RAO position to show you where is balloon that is quite close to the contour of the heart. But I think so it's okay there.
Let's pace.
Let's pace.
Can we see the
We have a
signals
nice
and the
response. Okay.
potential?
We are now inside. You can see now the balloon is not round shaped because it was going inside the vein. The right superior is really quite big one. We can't go to the vein with balloon with big pressure. Now it's okay. So we can ablate here. Breathe, please. Start breathing. We can't push much to the balloon because otherwise the balloon is going inside the vein.
That's what I mentioned, that it's the most rounded vein, usually the biggest one, unless you have left common trunk. So anatomy
Yes.
just
It's so big.
explains.
Can you show us? Yes, you can see that this vein is really big and we can easily go inside.
Yeah.
And you see the delay of the potential in the
Yes.
LA lead.
You can see there is still not isolated, but it is a big delay there. Can you show it, please? Sarah,
Yeah.
please record it.
Yeah, we see it.
Yes.
We see it
show,
on,
show the signal in the vein.
We see it on live
It was very nice on the live screen.
screen.
Meanwhile, there are some questions, if I may ask. There are two comments about this big chunk of ice that we saw on ice. So, whether you are concerned with this or not, whether you've seen any ST elevations, for example, or stroke or something temporarily neurological. I guess I know the answer,
No,
but
no. We never seen it. There is no stroke, no TA, nothing. But still, we have this signal, so the vein is not isolated. So maybe we can stop it at the moment.
Oh, 36.
Stop pacing. The signal is very late, but it's not isolated.
Oh, you have to go a little bit more.
So it's not it's not easy here because if I push too much, the balloon is going inside. If I not push too much, then the vein is not so perfectly occluded.
You have to push
So
in
we can
between a little bit.
Yes, I try. So inflate, please. And deflate again, please. I try to go to another branch if it's possible. But probably there is no other branch for superior vein. Okay, so can we inflate again? Okay,
Push more technique.
I try to push more.
There is question, what
Slightly
is...
inside the vein, but
there is a question, what is average...
we can ablate. Pace, please. And we can ablate here.
can we see the signals now from the diaphragm?
It's yes.
Perfect.
Actually, the second signal is just a far field from the QRS.
It is a little bit deeper, so we don't see the signal here.
Looks that there are no signals now
In the vein
in
anymore.
the vein. But maybe...
Yes, it moved. Sorry, stop it, please. I pushed too much because the balloon dislodged. Did you see it?
Not really. we were focused on signals, not on the balloon, but I did not see.
I pushed too hard.
There was a question, what is average procedural and fluoro time for these procedures with the eyes guided?
We don't care too much for fluoro time. We care on the dose, and average dose in micrograys per, not centimeter, but square meter, in average is below 100. So the dose is really very, very low. We are using ultra low dose mode of the X-ray. In this case, if the patient is too big, too obese, we are not using this ultra low, but only low dose. So at the moment we have 255 micrograys per square meter, not centimeter.
That's a very good comment because people are obsessed with fluoro time, and fluoro time has no meaning practically. I mean, of course, it has meaning if you have 2 minutes or 2 hours, but generally you can have 10 minutes fluoro time and 5 times less dose than opposite. So it depends on other factors like frame rate, oblique projections, etc.
Can we freeze?
I think, guys, we can go to the next door because we need to update.
Can you then show the results? Okay. So thank you.
Can we move to the other lab, please? Can we show again Dan with cardioneuroablation?
A vidíte, že to se povedlo tady. No. Já udělám pull down tady.
Okay, we can see you then. We don't hear. Okay, we can hear you.
Can you hear me?
Yes.
Yeah, perfect. So we ended the transmission when we did 2 deliveries, one from left and the right side, and it appeared that it completely eliminated sinus nodal response. And there was AV nodal response also some was affected, but there was still some residual AV block 221. And just now I want to show you the utility of left vagus pacing, left vagus stimulation, because this was done during right vagus stimulation. So please, I'm adjusting the position in at the first at the right vagus, and we will repeat the pacing. There is just to know if there is sort of recovery or something like this. So I'm ready. Yeah, position is all right. We may pace in sinus because there should not be slowing of sinus. And yes, you may start. Prosím, relaxaci zase další, máte to špatný strašně. A už to nechci to pořád opakovat. All right, so there is clear recovery, yeah, you see? Mm-hmm. We tested immediately after you started looking at cryo, and there was a very small response of AV node while pacing of right vagus, and when we went for stimulation of left vagus, there was a long pause. And now there is sort of recovery because even when we now pacing from right vagus again, there is long AV block. All right, so it is time to it's time to go for ablation of inferior ganglia, and now the sweet spot is that dark violet point. It is at the inferior part of the inferior rim of the fossa ovalis. It is plus minus in the middle between inferolateral mitral annulus and inferior ostium of right inferior vein, just in the middle. And I don't know if can you see eyes? Yeah,
we can. It's visible nicely.
Yes, all right. I am trying to adjust the position of the catheter by ice to improve the contact and stability. And it is exactly the optimum position. Now we are at the base of this pyramidal space, which is delineated by the inferior part of left atrium, by the coronary sinus, and by part of right atrium. Maybe include right atrium into our carto map. All right, a normal transparency without this, without sinus activation map. All right. And please insert also for a while the coronary sinus, just to see everything, all three structures. All right, perfect. So now you see the position, and of course it is also visible on ice. So 30 watts, 30 seconds. This is sweet spot for AV nodal denervation, and sometimes a single delivery here may be effective, fully effective.
So during you perform your ablation, there is a question from the audience: what type of stimulator you use for vagal nerve?
Yeah, I will just simply wait. I will answer after the delivery. Because I have sort of poor stability. No, stop. I would like to apply it again because it was stable until maybe only less than 15 seconds, and so we will. Ablation. It's not stable. Dejme pryč ten koronární sinus. Bod. Ten tam nechme, tam ty vyhoďme, tam jsem vždycky jenom chviličku. All right, this is special stimulator. This is not commercially available. It was designed and developed by Jose Pachon from Sao Paulo, Brazil. And of course, many thanks that we are able to use this because. So normal stimulator that is used for EV procedures doesn't offer enough output, and this frequency maybe frequency yes, but not such high output, which is essential for vagal stimulation. All right, so we delivered some energy. It was a little bit unstable, but. I think we may test just now because there might be effect. We will start with the right vagal stimulation again. I will adjust the position of catheter at the right jugular vein, and again stimulate. Yeah, it's not bad.
A real sweet spot.
I can't see any. Yeah. So I think, and now we will recheck. We will recheck with right vagal spacing. Sorry, left vagal.
Left.
So it was right, and now I'm switching for left, and there might be a response again because we know this predominantly supplied by. Left vagus. All right, I think the position is exactly at the same side as at the baseline. And please pace again. Stimulate, not pace. I see. So if you pace only, right vagus only, you may think that you already denervated AV node, but this is not true because there is still long pause. All right, so we will continue ablating.
So there's a question regarding this. Why do you not ablate at the superior part of the left superior pulmonary vein or roof? Because sometimes you may get better responses in AV nodal conduction rather than this inferior point.
We investigated this in recent years, and our conclusion was that the role of superior left ganglionic plexus is the least effective compared to septal ganglionic plexi. For example, if you start with superior left ganglionic plexus, you may have some vagal response acutely during ablation. But when you retest with extracardiac vagal stimulation after a couple of deliveries at the site of left superior ganglionic plexus, there is very rarely any response of or improvement in responses of SA node and AV node as well. Very infrequently, when we are not able to eliminate all AV nodal responses by ablation of inferior ganglia and by ablation inside proximal coronary sinus, we may end up with ablation at the region of left superior ganglionic plexus. It may help us to finalize this AV nodal denervation lesion or configuration. But this is very infrequent. I guess it is needed only in 5% or maybe less than 5% of patients.
Okay.
Now I go for, this was sweet spot number 1. The sweet spot number 2 is somewhere here, blade here, 30 watts, 30 seconds. It's a little bit closer to mitral annulus. Ještě dám jeden bod, jo, protože to se tam sedlo moc k té fose, jo, takhle je to lepší. Tam ten bod vyhoďme klidně, tam jsme byli na chvíličku.
So maybe you can comment on how you select those sweet spots. It is based on your experience of doing these procedures.
It is based on learning it.
By burning.
It's burning by learning. Learning by burning, vice versa.
I mean, you can maybe comment that we did use also MIBG, and we did some studies with the stimulation inside the heart, and none of them was really accurate enough. So this is some kind of empiric approach.
Vyhoďme tam pár těch ablačních bodů, aby to bylo vidět dobře. So
there is another question that goes.
More lesions here, closer to the mitral annulus, and then we'll retest again. We really excessively, this experience comes from really excessive use of extracardiac vagal stimulation. We, in some patients, do this testing almost after each delivery, and it is perfect teaching tool. All right, so I think we may, again, I will not go back to right vagus, because it's completely useless. There was no response already after this first inferior ablation, and we will test only using the left vagus. So I'm checking the position of the catheter at the left in jugular vein. It's correct now, and please check again. Still long pause, all right. All right, so I think the next step is to go to coronary sinus.
So maybe you can comment on how many cases of the cardioneuroablation you did, and how many cases was to do this sweet spot selection.
I think the total number of procedures that have been done here is 130. We started in 2014, and that it was first procedure, and of course the progression of procedural rate was rather low, not because of our inability to ablate, but because of poor referral, because the method is almost unknown that it exists. So, but in recent years we do 40 or 30-40 procedures per year. So I'm trying to engage coronary sinus. Please Pomozte mě nějak mě s tím hejbněte, jo, ať se tam dostanu. Lao. Ještě pořád za mnou. Jestli tam nedostanu, tak jo, už tam jsem. Dobrý, dáme tam. Tak, teď bych možná prosil. AF. Dobře, tak kardioverze.
Okay, we got an AF, so you will cardiovert.
Máme zrelaxováno, jo, teda.
We can maybe sum up in the other room and come back. Oh, you will continue? Okay.
All right. Yeah. If they have anything to show, you may, because it will be not straightforward just now, because again, empirically, if there is no response, nice response after 1 or 2 ablations, sometimes it is really hard to denervate the AV node. So we will continue ablating more extensively than for sinus node. Možná odhoďme, dá se ten CES odhodit nějak, jako, nebo aby tam nebyl ten...
Do we need to denervate both for a syncope, or is there any difference?
Tak počkáme, se to trošku ohřeje a zkusíme tam hockey stick.
So,
určitě je to dolní větev tady.
You are now in again.
Tak můžeme nafouknout, prosím?
Robert, teď jsme zpátky na stále.
Yes, yeah, okay, now we can see you.
Can you update
We
us?
have waited a little bit for you. We, in the meantime, isolated with previous ablation right superior vein. Can we show us signals before? It was signal in the ostium of right superior pulmonary vein. And can you show signal after ablation? Please, after one. And there's a small signal that just on the beginning of P wave. Maybe you've seen during previous ablation that was a big delay of the signal in the pulmonary veins. So right superior is isolated, and we are now with a chief inside inferior branch of right inferior vein. Can you show us CT? It is the orifice, the circle, the blue one. We are there with a chief, and we can go with ablation to this vein. Vypnu balon, prosím, vyfouknu. Okay, can you inflate, please? Yes, please. I try to go there with this maneuver. Do you see me? Oh, nice.
There's a big shadow there.
Because the patient is really big and there is a thick septum, we can't see it too much. It's not ideal to show you the position of ablation catheter, but the occlusion is quite good.
Decline the probe a little bit more. It's like viewing it from below a little bit. Yeah, that's visible balloon. No.
Here you can see it part of the balloon.
Yeah.
So pace, please. Pace, please.
Can we see the signals now for the diaphragm?
Yes, you can see it. It's pacing, diaphragm is moving. Patient is sleeping.
There is a comment that you have achieved quite deep, so practically never you see good signals during application. So.
There are two types of balloon. We call it with long nose and short nose. It is the tip behind the balloon. We are using preferentially the long nose, which is about 8 millimeters. We use it, we prefer it because it's more stable position in the vein, but the disadvantage is that the achieve is quite deep in this type of balloon, so we sometimes don't see signals and don't see isolation.
Online.
I do small pull down now. The temperature is not very good. Maybe we tried another branch of this vein.
I think we have to close. We are close to the end of the live cases.
Maybe you can go for
Yeah.
down and we back.
No, well, we cannot
our
go.
lab,
We
okay?
cannot go back. So I think you nicely introduced the ICE-guided cryoablation. So thank you very much for live case, for presentation, to all of the staff, and yeah, thanks.
Thank you.
Can we move to the other lab
we see Dan still?
for 10 minutes, and then we can restart the sessions.
Necháme to být, jo. Heda.
Dané,
38 grádů.
Stop. To vylítlo.
Dané, jsme zpátky. We are back.
Yeah, all right.
But we have only like 10
Wait a
minutes.
minute. We will give last delivery here. Wait. What? Terrible. And I will explain what we did so far after this. Ještě jeden bod. Trošku to natáhneme. Dobrý.
There is a question for you, Dane. What is the success rate? But you
All
will
right,
have you will have lecture about this, so you will answer it probably during lecture.
Yeah, definitely. If can I continue with live case, or
Yeah,
is this almost the
continue.
end? Because we
No.
started 15 minutes
Continue
Later.
with
Continue, go, go,
continue
go.
with live case.
after the schedule.
Yeah.
All right. So what we did after there was still a response of AV node after endocardial ablation at the middle of bottom of left atrium, also at the more annular sides. We went to coronary sinus, and we delivered 3, maybe 4 ablations here, 20 seconds, 20 watts. And after that, we retested again by pacing, by stimulation of left vagus nerve. And you see this on review screen. Maybe, I don't know if you see review screen.
Yes.
Yeah, this is review screen. And there is already no loss of conduction, but there is still AV block first degree during the stimulation. So there is some residual conduction. And that's why we continue here in the inferoposterior. Prosím, natočte trošku mapu. We did these ablations in inferoposterior part of right atrium in the proximity of inferior vena cava. And now we assembled the ablation spots around the base of this pyramidal space. And we do the because this is the main ganglionic side here, relevant to sinus AV node, and I'm adjusting the position of the catheter inside the left jugular jugular vein, and we will pace again. All right, please stimulate. There is again prolongation.
But much better response than what you had.
So, all right. So still some response, and I think now we will go back to left atrium. So potřebuji vyhodit pravou síň CS a ukázat zepředu. Dejme signály zase 200. Plnou transparenci. Zepředu já lezu do síně. I need to get back to, all right. Trošičku nahoru, abych viděl jsem u ty díry. A tam nejsem tam, nadzvednout. Dobrý. Nadzvedneme nahoru. Já bych možná, ne, já udělám něco jiného. Půjdeme ještě, dáme PA nadzvednutou. All right. So, if it is not effective, we ablate it in the middle at the mitral annulus, and now the next step is to go along the inferior portion of inferior ostium of right inferior vein. So I'm adjusting the catheter to be nicely there. Trošičku víc nadzvednout, já už tam skoro ztrácím ten pohled, jo. No, tam nejsem. No, teď už tam. Potřebuji to ještě trošku nadzvednout, já se fakt nevidím, ani za boha. No, nevím. Tak to uděláme jinak, dáme RAO, to půjdu ze zhora. Sometimes because our puncture is in right atrium. Our puncture is very close because of these difficulties at the beginning. The transeptal puncture is very close to the right inferior vein, so I have problem to ablate the ostial part. Trošičku za mnou, bych viděl, že lezu do té díry. Dobrý, jsem tam? Nejsem. Já začneme ablovat tady v tom vestibulu, půjdeme dolů. Because of these difficulties, I suggest ablating right anterior vestibule, because this is very effective in terms of AV node. Ablate here. And I will drag just in craniocaudal direction. There is no need to ablate 30 seconds, 30 volts at each side. So this is less specific ablation.
Can we see Carto to see where you're ablating? Yes, thank you.
So it's in between, more or less, superior, inferior vein.
Anterior carina, yeah.
It's like when we want to isolate the right veins. We are on the large perimeter outside of ostia in wide antrum. Dál. Ještě to opravme ten bod. Bod. Stop. And we will recheck the response of AV node again. So I'm adjusting the position. Prosím, srovnejte hlavu, dělejte to vždycky, jestli můžu poprosit. Jo? Já nemůžu myslet na všechno. Jo? Už jsem to řekl asi 1000krát. Ať se dívá rovně. Tak, můžeme stimulovat. Yeah, it's perfect. Yeah, you see? There is no prolongation of AV. So I think this is the end. Now I'm thinking whether just to increase the durability of this response of this ablation effect, we may give some more safety barons to the right atrium because there is only single baron. But we will wait for 15 minutes just to, if there is no recovery phenomenon, we may end up with this lesion. So it was very easy for sinus node. And it was a little bit more, not so easy for AV node, but in some patients we end up with even more extensive. Sometimes it's very, very tricky to ablate AV node. So if you have any questions.
I think there are some questions, but we will leave them for a discussion after the session.
All right, perfect.
And
perfect.
I just would like to emphasize that this is a really nice technique to check if you did something, because this is a difference from renal denervation, for instance, where you do something and you don't know what you've done. So here you have clear endpoint where you can really see abolition of the reflexes, and this is related to clinical effect, and this will be topic of Dan's presentation. So thank you very much for nice demonstration of this technique, and we will discuss during debate all questions that arrived during this live case and were not answered yet. So thank you very much to you and to all staff.
Thank you.